Good afternoon. Great to be here with you all. Now that's smarter, agile public health action in real time. So thank you all for being here. We're going to have a great session. I have three wonderful panelists to share some insights and lessons about how do you move public health to a smarter, agile place to really do what we all go into that work doing, is change the health of a community, state, and a nation. And my name's Jay Bott, and I dance because it's the best way I know how to say thank you. People know me, know that it's the best way that I show my gratitude. I actually teach patients weekly at a dance class in the northwest side of Chicago. After clinic on Wednesday nights, do 4 6-week sessions. And it's not just about dance, but it creates community, and it creates a place where people are able to engage in the issues that they fear most. And so I had a woman who was 36, her mom died of breast cancer in her 40s, and she didn't want to get a mammogram for 3 years. And we asked her why, and she said, because I'm afraid. She was a single mom of 2, didn't want to tell her kids. She felt like, look, I have breast cancer, and I don't want to deal with it. And so I brought her to the dance class, and she talked to another African-American woman who had the same decision point, but decided that she wasn't going to get one either. And she ended up with late-stage cancer and all the complications of it. And they didn't dance at all. They basically heard the music, but just spent a lot of time talking to each other. And that relationship, at the end of it, that conversation, my patient said, Doc, I'm going to get the mammogram. And we caught her with early-stage breast cancer. She's doing well now. Her 2 kids are doing well. And so it's really about creating a space for opportunity and action for people to change their health, but also making the healthy choice the easy choice, making it easy to do the right thing. And we hope that health data, public health data, makes it easy for us to do the right thing. And so in Chicago, where I spent a year and a half as a managing deputy commissioner and chief innovation officer, that's what we tried to do. And I say that the public health workforce of the 21st century are going to be people like those sitting in this room, the residents of our communities. And we did that. We took the civic tech community in Chicago, which you'll hear about after this session, and brought them together with a particular thing that we observed. We observed that there was a lot of tweeting happening about foodborne illness. And we said, hey, there's something to this. And so engaged the civic tech community to help us build a machine learning natural language processing algorithm called Foodborne Shy, which is built into the city's 311 system with the service tracker number and all, and looks through all the tweets in Chicago related to foodborne illness per the keywords we identify, and sends those, it goes through a classification system, which then we send a tweet back out to the residents saying, you might be sick, we're sorry, here's a form you can fill out that talks through the details of the potential exposure. That comes back to food protection. Food protection investigates the establishment and then puts the results up on the open data portal so that there's a closed loop, there's a service tracker number, and there's been incredible results from that. In 10 months, 2,200 tweets classified. Of those, 137 turned into inspections. And of those, 80% identified with violations. So we're actually, to make this real, we identified a hotel outbreak before it actually hit 4 days before it hit the news, and try to get out in front of things that happened before. And we've taken the similar concept around predictive analytics and built an algorithm using open data that's out already on the portal to predict which restaurants are most likely to have critical violations on their next inspection, and targeting our inspectors that way rather than the 30 inspectors for 16,000 restaurants have been typically targeted by doing the zip code beat that they typically do. And we've done the same with lead, West Nile, and breast cancer screening for women at high risk for premature mortality to breast cancer. So a lot of that was because it was really partners that wanted to engage and wanted to make the city better. And we've been able to share that work to help other cities think through it. And so you'll hear today from 3 wonderful folks who are really using different techniques related to health data, both to be at the cutting edge, to learn insights, and to take those insights and tie them to interventions. Because data alone doesn't really matter, right? You've got either connected to a story, connect to an action, connected to an intervention. And so we hope you'll learn about some of their experiences, the successes that they've had, some of the challenges that they've faced, and what they see as the opportunities for public health data moving forward. And so with that, I'll introduce our three panelists. We have Leslie Rafe, who is a senior epidemiologist from the county of San Diego, and she'll certainly speak to more of what she does. And one of the questions I asked is, if you were going to be in a movie, you all should think about this too. What movie would you want to be in? What character? And so Leslie said World War Z or Outbreak. And if World War Z was Brad Pitt, if it's Outbreak, it's Dustin Hoffman.
Because they got the helicopters.
Because they got the helicopters. Well, while Leslie's coming over, let me introduce the other two panelists. We have Muntu Davis, who's the Public Health Director and County Health Officer right here at home in Oakland at Alameda County, and so this is home turf for him. And if he were in a movie, he'd be playing Wolverine on X-Men. Yeah, so it tells you about how much good trouble he creates here in the county of Alameda for the health of the residents here. And Dr. Anish Mahajan and Dr. Muntu Davis, are along with Leslie, have different perspectives coming from different environments. San Diego, here in Oakland, and Dr. Anish Mahajan from Los Angeles with LA County. And he is the Director of System Planning Improvement and Data Analytics. And so we'll look forward to hearing from them, and then we'll engage in a discussion.
What was his special character?
Oh, yeah. Great. Thanks for keeping me honest. Look at that. Anish says that he wants to be cooler than he is now. And I think he's pretty cool. So he said he would be Fox Mulder from the X-Files. So that's where he would be. And so TV shows are appropriate as well. But it was a movie too, I think, right?
That's right.
Yeah. There you go. All right. With that, thanks again, and we'll have Leslie kick it off. And one of those mics should work. Yeah.
Hello.
And I can have this one just
Okay.
there as well, whatever works for you.
All right. Okay, so we were asked to just talk a little bit about what we do. I'm the senior epidemiologist at Public Health Services, Health and Human Services Agency for the County of San Diego. I'm pretty much responsible for population health analytics for 3.2 million people, 30 million overnight visitors a year. Think about that. We have 10 times more overnight visitors than we have residents. We have one of the busiest international land border crossings at Tijuana, or San Ysidro. And our population is getting more divided. People think of San Diego, oftentimes they'll think of La Jolla and the wealthier parts of town. We also have a considerable population that is in need. And we are a majority county, which most people wouldn't think of. We are about 47% white, about 35% Hispanic, 15% Asian or Pacific Islander, which is one of our fastest growing racial or ethnic groups. Surprising. 5% of our population is mixed race. And pretty much as I start to look at population health and I look at the demographics, one of the things that concerns me is we do a lot of tracking by race ethnicity. In 15 years, I'm not going to be able to do that, and so I have to start looking at other ways of categorizing, classifying people. And so one of the things we're looking at is socioeconomic status, which actually is class is almost a much better indicator as we begin to evolve as a society. I look at things like education and access to digital divide in terms of the impact they have on health and well-being. I'm really fortunate to work at one of the few agencies, local agencies, that is a health and human services agency. So it combines the functions of public health, behavioral health, aging and independent services, child welfare, the social services, all into one agency. Essentially, we're caring for the whole person or the whole family. And we do this through something called Live Well San Diego, which focuses on and integrates program, policy, and measurement for our entire population in terms of health, safety, and thriving. It's just the way that we're doing business in San Diego. We're looking at all of the impacts of everyone. Now, some of the things that we have done that have been new and innovative, we really started establishing a structure around health data years ago. I'm insidious. I sneak my way into things that, like, you wouldn't believe. Years ago, we started organizing our emergency medical services data around geographic units, not individuals. Because basically, there was a whole lot of information, but was wrapped up in individual patient records, which we can't access in a widely shared way of looking at things. We need to look at the aggregate so that we can get that information out. So by using geographic units or neighborhoods, we could produce lots of information for planning purposes, for quality improvement. Now, quality improvement is different than quality assurance. Quality improvement means, how do we improve the system? How do we change things to make it more responsive, make it better, meet the needs? Quality assurance is really looking at the individual level of care. So we also are using a lot of this data in this data structure to predict the future needs that were previously hidden in these individual records. Well, I got away with doing that, and then I started talking to my colleagues over in other parts of public health who are epidemiologists, and slowly but surely we got the rest of public health on board. And now we have standardized or structured all of our health data around the same format. So you can go online to our website and you can get data on heart disease or on pedestrian injuries or on Alzheimer's disease and compare it directly to each other. So in lots of places, organizations will report their data specifically by, well, this community wants this number, so that's all how we produce it. What we've done is we've standardized it so that we can have comparable data. One of the first questions I got asked was by the then public health officer when I got to EMS was, how come when I ask this person for how many people died and then I ask that person for how many people died, they give me different numbers? And I go, they're interpreting the question the way you ask. They're interpreting the question through their database, what they have access to. So if we standardize how we interpret the question, then we have data that has much more value and is more meaningful and of use to people who want to begin to look at data and how we can compare across. Because really, how do you say heart disease is different than child pedestrian injuries? If you're trying to allocate resources, you need to know the numbers, you need to know the rates, but you also need to know, are they impacting the same populations? Are they impacting the same age groups? Are they impacting the same race, ethnicity? What are the cultural issues and factors behind these? So what we do is we organize all of our data by community, by age group within that community, by gender, and by race, ethnicity, all within these communities. So if you want to know what the biggest problem is in your community, it's real easy. You can go in and you can compare all of our data. And when I'm talking about data, what I mean is we have all of our chronic disease data, we have communicable disease data, we have our maternal and child health data, we have injury and violence data, we have behavioral health data, and then we have Alzheimer's and other dementias data, all posted online by this format that anybody can download as a PDF. However, at the end of this month, you will be able to download it as a machine-readable file. All of that data. Most of the data goes back to 2010. Some of the data goes all the way back to 2000. So this is a pretty awesome step for a county to take. But our director refers to this as harmonizing our data to humanize it. And that is very true. By standardizing it, we are literally making our data usable across our agency. But humanizing it requires more. And so one of the things we've done is added marketing data to our data mix. Okay? If it's good enough for fast food franchises to use this data to determine where to place restaurants, then it ought to be good enough for public health to figure out where to place health resources and healthy options. And so for a ridiculously small amount of money, I mean, we're talking less than $5,000, I was able to purchase by census tract over 4,000 marketing variables that tell me which communities, what percentage of them are buying frozen orange juice or whole wheat bread or going to the optometrist for vision problems or have long-term care insurance or any number of things. This is an incredibly rich data source that everyone who works in public health should be accessing. So now, when we do things like look at obesity rates, we look not just at the rate of obesity, but we also look at what people consume or purchase in that area. Okay? It's really powerful. We've discovered in looking at this data across our communities that about 30% in each community, 30% of the food dollar goes to purchase junk food. Think about that for a minute. Public health has been spending a lot of energy and a lot of money on eliminating food deserts. It seems we're asking the wrong question. It's not do people have access to healthy food, it's what is driving the purchase. And socioeconomic status, again, a stronger indicator of health disparities. So we're going to be adding socioeconomic status in the near future to how we analyze our data, so just as one more. And then we're also looking at ways to incorporate psychographics, which is another way marketers look at you and what you buy. And we'll be including that into our external data portfolios that, again, will be available to people who want to look at our communities. Are we done?
Yeah. Great. Well, that's fine. I'll do it. Thanks, Leslie. We'll give her a hand of what's happening in San Diego. And I think what Leslie is introducing is this idea of it's not just about standardizing data, it's not just about putting it out there, but it's also about putting that data to work, right? And so I think that that's really the important piece, and we'll see more of that certainly from San Diego and from some of the things that our next speakers talk about. So I'd like to bring Dr. Muntu Davis up. Yeah, you can stay. Just move over one. And as you come up with thoughts, feel free to also interject if it's compelling and related to some comment that the speaker's making. But we'll have time to have a discussion after.
Good afternoon. Everybody hear me okay? Yeah. Good. So I recognize that some of you are going to be visual learners, so I do have some slides, not just words. So I want to talk a little bit about where we are now in terms of Alameda County. We're a population about 1.6 million and actually have double the staff of what you guys have.
Yes, we know.
Yes. I'm trying to figure out how we can get to yours.
Dale Fleming, our director of strategy.
Yes. I've been trying to ask MoMA, their health officer. We're one of the most diverse counties in the state of California, and also have some high morbidity in relationship to that. But I want to also talk about our mission. And so our mission is really to work in partnership with the community to ensure optimal health and well-being for everyone, for both present and future generations. And it's important for us to think about future generations because we can provide enough services, but that doesn't necessarily mean that future generations and even some of the environmental factors that we run into that drive health as well also get addressed in the work that we do. The other thing in terms of our vision for Alameda County, which really drives a ton of our work, is that everyone in Alameda County, no matter who you are, where you live, how much money you make, or the color of your skin, can lead a healthy, fulfilling, and productive life. Now, in this, we used to often say that they had the opportunity to lead a healthy, fulfilling, and productive life. But in essence, that's not what we want. We want people to lead that. And so we're very keen on saying that that's what we want and not just talk about opportunity or access. When we talk about opportunity or access, sometimes it's about just services when there are other factors that come into play related to people's health. So this is our framework for health equity. Many of you may know in terms of our department that we've been focused in on health equity for a very long time. And it took about 10 years for people to actually understand and get the concept of health equity. And this framework was really used as a way of describing what we were talking about in terms of how we end up with the health statuses that we end up with. And it begins with data. Notice that on the right side, it starts with mortality in terms of thinking about who's dying, what are they dying from, and looking at those diseases or injury, also thinking about the individual risk factors and exposures that they have. Now, traditionally, as a medical physician, I'm taught to sort of think about individual risk factors and what they're exposed to. And that's really what we call the medical model. When we really talk about public health, we still go for that in terms of the individual risk factors and risk exposures, but we're also thinking about what are the things that drive those. In terms of whether or not it is a food desert or not, in terms of whether or not there are high rates of smoking, are there more liquor stores or stores that sell tobacco, more advertising, those things that actually drive behavior as well. And so we have to pay attention to those. We can't just stop there. We have to think about what are the institutions that actually drive those? What sets up those neighborhood and social conditions? And is there an opportunity for things to be done a little bit differently? And when we do that, we have to think about not only the assumptions that they make or the biased beliefs that they have. And that often comes out in terms of policy or practice with those institutions. And an institution like us as the Public Health Department. There are certain things we walk into with certain assumptions. Whether or not those assumptions are true or not, we hope to prove or have some disbelief in terms of it, in terms of the data that we use. But if we don't pay attention to those assumptions, we can never change how problems are talked about. But the basis for most of our discussion starts with data. That's where our credibility lies as a public health department in terms of extrapolating what that data actually means and thinking about what beliefs or narratives that people have about certain stories. Many of you see this when we talk about obesity. It was all about individual choice. People are just not exercising, they're not eating healthy food. But then when we look at some of our neighborhoods, there really are things that don't allow people to do the things that we think they should be able to do. And so we have to pay attention to those. In terms of our equity work, we really look at it from really three pillars. One is that there's certain things that we have to do as an institution in order to change how we look and think about the work. How we understand the data, how we understand the impact of our programs, and the data that drives that. And also thinking about institutional power in terms of, community power in terms of what the community understands. And usually that's bringing them data in order for them to be able to advocate and say some of the things that I cannot say as a health officer, that we cannot say as a public health department. And in that, we also have to think about systems change. It's not simply that one institution drives everything that we see, but it's the constellation of institutions working together. As you heard in terms of the criminal justice session, how many different laws and regulations we have in terms of folks who have felonies and what that does. Those laws cross various institutions that are in different sectors. And that in and of itself creates a system or a structure that each individual person has to deal with. But at the heart of all of this is our data and research in terms of what we look at. So to give an example, and for the epidemiologists in the room, I know we always have trouble with this because I don't have an x-axis. Okay. I'll admit it. but I'm telling a story, okay? And this is based on real data. Understand that this is really just the concentration of a burden in terms of limited food market access, liquor stores, toxic fuels, and housing cost burden and unsafe streets. For whatever those measurements are, whether it's a concentration of sources or a score factor in terms of like limited supermarket access. Looking at this from the standpoint of socioeconomic status of the neighborhood, the highest over here being the high poverty neighborhoods and less than 10% being poverty being the most affluent. And so we see the concentration of these factors inside the neighborhood. And so when we look at what happens in terms of health status and why the differences, they're pretty much correlate. They're not in terms of the same intensity, but they correlate in terms of where you see the highest disease burden, where you see the most unintentional injuries, chronic disease, in relationship to those same sources. And as I go back here, notice the intensity of toxic and chemical fuels. Okay. It drives a lot of what happens in terms of the health status. And so we often have to change the narrative in terms of if this is what poverty is, it's not simply poverty by itself, but it's the conditions that come up with that sort of envelop or come from poverty. And we have to show the concentration based on data as to why the health status is different. It's not just because they're poor. It's because the environment is poor and we haven't invested in it well enough. And we use data often to do that. Now, if you think about it, the things that I show here, are they controlled by public health? Most of these, no. Where are these controlled? Who shapes these?
Private sector.
Private sector.
Regulation.
Regulation. Cities. Cities is the magic answer in that. It is part of regulation, it is part of private industry, but if you think about it, cities can often influence that. There was a report done by an organization called Kausahust or Just Cause that we helped them analyze some policy factors around development and displacement of existing residents. And in that, did an interview with KQED, and they talked about, well, it's just the market. It's what happens, when factors get to be a certain way. But the market doesn't operate by itself. It operates off of some regulations, some assumptions, and some rules. Okay. Cities often will think about, if you see in affordable housing, when a new complex is being built, they may say, okay, we'll give you some money or take off something in terms of what we can do or fees that you may have to pay if you put affordable housing in there. So that changes the market. What happens in terms of schools, where things are located in the neighborhoods, that all comes from what the city decides to do. And so how do I change their thinking? How do I get them to think about those things? I take data to them. We did this last night. I was telling Jay that we had a talk about the housing crisis in Oakland. And one of the things that doesn't ever come up in that is how does housing actually impact health? And so I went and talked about how housing is linked in terms of poor health status, both in terms of affordability, habitability, and access. Again, sort of thinking about the public health consequences of that and the data that goes along in order to demonstrate that. And so we use a lot of data in terms of shaping how people think about the problems and what assumptions and the narrative that they tell in terms of those issues. And in a lot of cases, the data that we show actually helps them to think very differently and challenge their assumptions. In this, one of the hardest things about looking at, if you want to say return on investment in terms of health, is thinking about how do you actually show or how do you actually predict it's going to actually change. Community transformation grants came out in terms of the Affordable Care Act and all this money and the prevention fund getting attacked. And the community transformation grant said, look, we want you to change heart disease in 2 years. Who thinks we can change heart disease rates in 2 years? Now think about the data that we look at. We look at data that's prevalence data. Prevalence is both new cases and existing cases. If you think about that equation, if I want to change heart disease, either the people that have heart disease now have to die off, or one, I have to truly prevent those who are already at risk and already on the edge of having heart disease in the first place. So what will be better for me to predict that I'm actually going to change heart disease? You might be looking at risk factors in terms of what things change in terms of habits. It might also be looking at incidence data, new case rates. But we don't often look at that data, and there's a need for that and to be able to extrapolate that from the healthcare community. We also have to think about predictive analytics, and that's one of the things we struggle with, is how do we use some of what we know to predict this neighborhood might be at more risk for having these particular diseases, and think about that more proactively, as was just mentioned by Leslie. So in essence, our data helps to change the narrative around things. We also have a lot of work to do in terms of our programs, thinking about the impact they have. If they're providing a service, what would change? We asked them in terms of looking at the data around what they report to their funders and said, is this useful for you? Does this help you to say that your program is actually doing something well and having an impact on your clients? And they said no. It's basically widget counting. And so we often think about, and we talk to them about, okay, what things would you measure in order to say that you've done your program is being performed well, and assess the impact that you had in terms of the clients that you served. And that's actually a rich conversation. It actually strives them thinking about what data do they really want to have, what data helps them to be proud of the work that they do, and what data really shows the impact that they have, not just the numbers of people that they served. Thank you.
Thanks, Muntu, and I think the point that Muntu brings up is this notion that data coming across sectors is real power, and that it has power if you look at it in a way that helps you make connections between unusual suspects, housing and health. One quick example is in Illinois, we looked at which county has the most per capita lower extremity amputations related to diabetes, and it was one of the southernmost counties in the state, more so than Cook County where Chicago is, by threefold. And the reason is a whole host, but one of the more interesting reasons is that it also has the highest per capita amount of liquor stores in the state. It also has the lowest amount of per capita places for physical activity, exercise, parks, space. So there's some interesting relationships that can come by trying to bring together this different data. And so here in LA County, Dr. Mahajan is part of a senior leadership team that's dealing with a lot of moving parts and a lot of pieces to try to bring data together and improve health. And you'll hear about that.
Thank you. Good afternoon, everybody. This is a real pleasure for me to be here and to speak with such an engaged and diverse audience at this conference interested in data. I'm going to steal Muntu's slide here because I think it's a brilliant sort of framework for how I like to think about data. I think of data as we've heard about sort of this idea that we need data to explain. We need to get data into people's hands who are decision makers, into community engaged groups, into our agencies and our operations, right? We need to be able to report and tell the story. That's one thing that data does. And I think our public health colleagues, Leslie, Muntu, in that middle box have done a very good job of collecting data, and they're figuring out how to tell the story, and they're doing lots of great success. I'm going to argue, though, that we've done a terrible job with data on the medical side. And that's a provocative thing to say because the medical side likes to think it's done a great lot with data, right? And I'm going to say that we have no idea what to do with the little data that we have upstream. We have no idea how to really measure those things. And so we're having trouble telling the story upstream and downstream. We're kind of doing a good job of telling the story around public health, about explaining things. But frankly, what data really, I think, needs to do is figure out how to, as Jay put it, how do we put it to work? So explaining is important. Decision makers need to understand what to do with data. But how do we get data to go between these, across up and down and back and forth between these streams, up and down, to help with the care of people, to help address social determinants, to help address their medical problems? And how do we sort of coordinate that whole thing using data and putting data to work? And that's something that we are trying to do. We have a vision to try to do in LA County. We have a lot to learn from our colleagues all around the state and around the country. But let me start by saying, so I work at the LA County Department of Health Services. It's the county department that does the delivery of health care in the safety net to Medi-Cal managed care. Medi-Cal patients, residually uninsured patients, for the safety net delivery model. We have 4 hospitals, about 20 clinics. We take care of about 750,000 unique individuals each year in our medical facilities. We also have a sister county department of public health the LA County Department of Public Health that sort of does the middle piece there and some of the upstream piece. We have a county department of mental health that takes care of the behavioral mental health challenges, and we have substance abuse care on its own in another agency, a sub-agency of the Public Health Department. So you're hearing what I'm saying here is we are a fragmented government approach in LA County, which causes difficulties not only in programming, but as Muntu said, it starts with data. We have trouble sharing data to tell a story across those domains. We have trouble sharing data to improve the care and make plans about how to create interventions that work. So I'm going to say a little bit about what we are doing in that regard in LA County. So I'm going to start by starting with the medical model. That's where I work at the moment, and what we're trying to do is use our data. Our primary objective for our data is to succeed under the Affordable Care Act. We're the medical model. That's our purview. Our goal is we have to somehow make sure our healthcare facilities provide the best medical outcomes for patients once they get in the door under the ACA. And under the ACA, of course, hundreds of thousands of people in LA have gotten Medi-Cal insurance when they previously were uninsured. Millions of patients remain residually uninsured due to their immigration status, and they are still the patients we need to care for. So the number one priority we have for the data infrastructure we're building in health services, LA County, is to figure out how to create meaningful medical homes for the patients that are now on Medicaid and for the patients that are residually uninsured that need a primary care medical home. And really to succeed in their outcomes, in outcomes that matter, not number of percentage of patients that got mammograms, but have we actually reduced the breast cancer rate among patients that we care for? To do that, of course, we got to be able to measure and do things within our facilities, but if we're going to have any prayer of actually affecting real hard patient outcomes, we have to get to what Leslie and Muntu were talking about, is all the other factors upstream that affect our patients. And so I'll say a little bit more before I get to the upstream part about what we're doing in our facilities around data and infrastructure. We've implemented an electronic health record system so that all of our hospitals or clinics are on one single electronic health record. This is important. Just to give a concrete example, if I'm a patient at hospital A, I walk into the emergency room, I get a CAT scan, then I go to hospital B, that's also a county-run hospital. It used to be that the docs in the ED couldn't even see the same record, so they couldn't tell what I got in my CAT scan, so they'd probably just repeat my CAT scan in hospital B 2 weeks later. So we've solved that problem. We've got one single electronic health record across our facilities. We've also made investments in other things like electronic referral for specialty care. That's something that they have here in San Francisco as well. The idea being that we have to improve access to specialists for patients. We've made an investment in electronic data, an enterprise data warehouse, to bring together all kinds of data streams into one single model so that we can perform the analytics and eventually the predictive analytics around all of the aspects that affect a patient's health care or health, right? So we easily can get the health care data from our facilities into the data warehouse, but now we are looking to obtain data from upstream into the data warehouse. And what are some examples? Some of the stuff that you've heard the panelists talk about, environmental health data sets, other kinds of public health data sets that then can be combined with the patients that we care for to be able to take into account those upstream factors that may be impacting their outcomes. So that's one of the approaches that we're trying to take. I guess I'm going to say a couple words about what are some future steps that we're taking in LA County. One of them is to try to build an electronic health information exchange system so that patients and people who get care in multiple kinds of entities, private sector, community clinics, and the county-run facilities, that their data is easily transferable across these former data silos, right? So it doesn't matter for a patient who's got a bad problem with diabetes. It doesn't matter where they go, but the provider who's taking care of them needs to know what's happened to them wherever they have been, regardless of what facility they were at. And so we're looking to build an electronic health information exchange, and we're making some progress in that regard. I'm going to just finish by saying that in LA County, I started with telling you about the silos: the mental health department, public health department, health department. We're all so siloed, and it's presented enormous challenges for us to really improve the care of people, right? People are not just their diabetes and then separately their depression. And so the County Board of Supervisors in LA just recently voted to integrate these departments in LA into a health agency. The decision to do that really comes from sort of many of the conversations that have been going on here at this conference, that if you're going to be able to impact outcomes, you need to be able to share data. You need to be able to plan based on data that is an apples to apples comparison. I think Leslie had a great example earlier of how do you measure something, and people are getting different numbers because either they're measured differently or they have a different question. You need to, I don't need to tell this room that you need to know you need to have an apples to apples comparison, and ultimately you need to be able to plan around that, deploy interventions and evaluate them. None of this has been possible in LA County to any significant degree so far in the recent history, and so the supervisor said, let's create an agency. The hope is that by creating an agency and combining some aspects of the administrative components of these departments, we'll be able to do that. And one of the primary drivers for the agency was not budget, was not cutting costs or creating efficiency. It was the data. It was this feeling that, gee, we don't even know how many patients at the health services department are getting care in the mental health department, and then getting involved in the justice system and the sheriff's department. We couldn't even create a number like that. And here we are, they're all county clients. We know there's overlap, but without knowing how many people are in this category and their characteristics, how can we develop an intervention? And then even if we did create an intervention, how do we evaluate whether it's working if we don't have data that can interact across these silos? So, it's an exciting time in LA County, and I don't have to tell this room though, integrating agencies like this comes with all kinds of politics and challenges, but the data challenge is a big one too. Normalizing data across these silos is going to be a big challenge, but I think most of us involved in LA County are excited to do this because we can see the potential payoff. And it'll be a work in progress, but it's one that we're excited to take on. I'm going to stop there and open up for discussion.
Great, thank you, Anish. So really, Anish went into the important aspect of, there is this disconnect between the data that the medical delivery or the healthcare delivery system has, that the public health system has, and a lot of work now is being done to try to bring some of that together. And I would agree that it's an extraordinary time to be in healthcare, and that it's not just the data that's coming from various sources, but it's also the data coming from, as Leslie also pointed out, from consumer purchasing data. In Carolina, they try to use credit card data to predict who would become sick. Louisville is using sensor data from sensors put on top of inhalers with a company called Propeller Health to understand when, how much, and where do people use their inhalers, to understand what the asthma map is. And that information is helpful not only for the delivery system, for the public health system. And that's important, as Anish alluded to, for planning, right? So whether it's environmental planning, system planning, and so forth. So it was a great introduction to some of the issues that surface around data. One I wanted to start off with is a question, and then, however you all want to engage and ask questions, we should go ahead and do that. One is that often with the digital aspect, there's this notion of a digital divide, and Leslie, as well as Mantu and Anish, can speak to this. Is that how do we ensure that, well, there's a growth in technology and data and analytics, that we ensure that we use that to reduce the digital divide and help those who are most vulnerable?
Is this working now? Okay, great. One of the fears around, and I'll get to your question, one of the fears around data, and I know this as a provider, is sometimes when you ask a question, you get some data, you don't have anything to do with it. So if, as a provider, I'm asking questions about food insecurity and I'm tracking that stuff and I've got this information, what do I do with that? That's not what we do. In terms of gathering data, I think one of the important things about breaking down silos is once you have that data is to think about who do you need to partner with in order to do something about that. And so I think part of that a little bit goes to your question about the digital divide. Sometimes I don't need to get that information electronically, but I need to understand what Anish is running into with their patients so I can figure out what I need to do on the policy and environmental realm as a public health officer and in the public health department in order to really work towards solving the problem that he's running into and solving the problem for more people than he's seeing as well in their system. In terms of the digital divide, I think it's often we get sucked in by what is there in order to grab. How do we grab that? And in some instances, I think just grabbing the information, figuring out how you might want to work with that information, who you may want to work with, and then figuring out that digital solution or the divide and trying to cross them that way. So I'm all for trying to figure out how do you want to work together, how do you need to work together, and then what digital aspects you need in order to be able to do that and facilitate that.
Great.
How many of you have an Apple Watch? How about a Fitbit? Okay. My staff doesn't count. There's a huge push right now for individualized medicine, for genomic medicine, for individual self-monitoring devices, okay? And how do we collect that data, and shouldn't that be driving health data? Shouldn't that be driving population health data? And this is where I get concerned, because half of my population doesn't have regular, consistent access to the internet. Okay, they have to go to a library or something like that. And when you start thinking about these just because we can type of inventions and really, brilliant stuff, and I'm not criticizing it at all, but my responsibility is for the rest of the population that doesn't have access to that. And how do we count the factors that influence their life and their health? Otherwise, we're going to wind up with these profiles based on upper income, relatively educated and wealthy individuals driving how health care will be provided or how disease will be managed for the population that hasn't been included in this. And so the digital divide to me is a really important factor. It's health literacy, but it's also computer literacy. I think that in public health, we really have to focus on the 75% of wellness that's due to behavioral and environmental factors, and not just on the health outcomes. And when we look at these, we need to understand how do we integrate information on social and physical environment in which our populations live? How do we recognize, quantify, and then ameliorate the stressors that they are confronting every day? And until we can figure out how to do that, we're not going to resolve a lot of our health issues. And I get concerned when I hear people talking about, well, we can do that, give everybody a Fitbit. And it's like, no, there's so much more than that. And that's what we have to make sure we're reaching.
Great, thanks. Any questions or comments from the audience? All right.
So I love the bar high graphic. I just could blow that up and put that on my wall. But my question is, as we, I work with Wilma, Dr. Wooten, who has beaten us over the head for the last 5 years that everything is health. Everything is health. I don't care what it is, everything is health. But when you go outside of the Health and Human Services Agency department to make that argument, if I've got health all over my document, then it's all your problem. It's all Wilma's problem. It's all your agency's problem. Is there been any thought to do a remix of the bar high graphic, which is very powerful, because in there is land use, there's public safety, there's libraries, parks and rec, all of the departments within the county, and many of the municipal services across cities. And as we're trying to engage people to understand maybe about equity and social justice, maybe those are other words that you can use, or just improved outcomes, or there's an argument now that equity is an economic imperative because you will drive yourself down the financial hole if you don't lift up those who are, not achieving at the same rate. Is there any thought to recasting the bar high graphic so that it's less health equity and more about pulling it all together to just improve lives across the board? Just a thought.
Yes. And so what you see is how we have to talk about it because we're public health. In order for us to be safely. Now, it doesn't mean that when we go out and give talks that we always say health equity. There are a number of times that I just say equity, and there's a number of times that I say fairness. Is it fair that over in this area, students don't graduate from high school as much as folks over here? Or is it fair that there's so many more toxic chemicals and fuel, sites or sources in this neighborhood versus these other neighborhoods? And I'm not saying that it should be equal, meaning that it should be spread equally across, but there's certain things that could be done differently. So although we cast it as health equity, we don't often talk about it. We modify depending on the audience we go to. So it's just for us in terms of thinking about how we sort of talk to people about why it is that we're talking about these other things, because it has an impact on health. But we often get into talking about it differently. I don't always show that framework. One of the things that we did a long time ago that I did not talk about, I think it was 2006, we did a report called Life and Death from Unnatural Causes. And basically, it took education, it took environment, it took transportation, it took housing, and showed how those things were linked to health in order to show the case why are we talking about it? Because we often get, well, why are you talking about transportation? I get the question, why are you talking to a city as a county health officer? And so when I explain why those things, it helps me to get some room to be able to go and approach those folks. Even though I don't often say, I want you to do this for health. I'm talking to you because it's an issue that impacts something I'm seeing, but couldn't it be better what you're doing right now anyway? And we work with them. One of the things we did with the city of Oakland, we've been working with them on what's called healthy development guidelines. Because there's so many different toxic sources. There's this question about, do they run coal through the new Oakland Army base in terms of a bulk terminal? And so we are able to walk in because there's a health context to it, but we often talk about it in a different way depending on the audience that we get to. So the framework works for us, but it doesn't always work for people, but it often works in terms of getting us in the door. But we do change the words that we use depending on the audience.
Great. Other thoughts, questions? I mean, I think that what also this conversation points to is this health and all policies framework, is which you're training and building capacity in other departments across agencies to think about how their work intersects with health. So, as you're redesigning a road or building a housing complex, what implications does it have for the health of the people that are the end users of that? So that some of that work is happening across states and cities as well. And certainly California has been doing a lot of the work around health and all policies. One of the other things that I came by that this group may be interested in is building the governance and structures to leverage health data effectively is hard, and takes some kind of selling, vision, and indication that there's a good reason in doing that. Can you speak a little bit, certainly about Anish, how you've set up some of the structures you have in government? What has supported your ability to set those structures up and gain some traction? And the others can speak to that as well.
Sure. I'll just give a quick example. We were talking earlier about examples. The way that we've tried to make the case for building a data infrastructure that unifies silos is by real world pain points that we're all facing, right? And so one of the pain points we have is our psychiatric emergency services. We have overrun PES, Psychiatric Emergency Services facilities, and a lot of different groups have a stake in the game, right? There's mental health, there's physical health, because we run the psych emergency rooms. There's behavioral health, substance abuse issues. There's the sheriff, who brings people to the psychiatric emergency services. And we didn't have a way of putting data together to understand what happens to patients who come to psych emergency services who are on involuntary hold. We don't have a unique identifier across these things. That's a building block you need if you're going to share data. So we did a probabilistic match of data across the sheriff department, the mental health, the substance abuse, the physical health, and the psychiatric emergency room. And we did an analysis to show people what are the outcomes of patients who come to the PES. And it was data that no one had ever really seen. It doesn't even exist in the medical literature and the psychiatric literature. And it was very illuminating to the stakeholders for a variety of reasons, but it made the case, it was an example for the various departments to say, you know what, we do need to unify our data. We do need a unique identifier across our silos. And so I think that's the way we try to do it, Jay. We try to show the value and then make the case.
Great. Well, our time is up, and so we'll close. Thanks, Anish. I think that's helpful to this group. The other thing I would say is, when I was at my role at the health department in Chicago, what we realized there just weren't the kind of competencies and skills we wanted to really push to the edge of how you can leverage data. And using new statistical techniques, programming techniques, analytics, machine learning, et cetera. And so really the civic community that is in cities and counties and states were really helpful. And so I encourage you to connect with these folks, because there are no shortage of problems to be solved to improve the health of our cities and counties and states in our country. And so you all are certainly important partners in that work. So thanks for being here, and thank you to the panelists for sharing their thoughts.